you're doing a case and on the face and fire starts, remember, first, turn off the oxygen. Number two, take the material off, and if it's the endotracheal tube, take the endotracheal tube out, and then care for the patient. So that's something that, you know, we don't get exposed very much, and I think it's one of the very critical things that we're trying to teach here. How many in this room know where there's a fire extinguisher in the OR, or if there is any? Yeah, we don't have any, and we have 21 medical centers in the same system. And so when you go back to your operating room tomorrow or next week, why don't you check what they do about fire safety? And some of you will be very surprised. Now, once all this happens, we need to report it. And so we try to make this a little bit multidisciplinary, and we have involved AORN, the Organization of Operating Room Nurses. There are 40,000 of them, so it's a large group. They're very interested in what we're doing, and they're very interested that it's done safely. And so we have today the privilege to have one of their president, Charlotte Gugliemi, who is going to tell us, once the patient is safe and the fire is extinguished and the burn is covered with Silvadene, what do we need to do to make sure that we are in touch with the regulations and so forth. Charlotte, thank you very much for coming here.
And thank you for inviting me as well. We're going to talk for the next few minutes about reporting adverse events in surgery. And so I have nothing to disclose other than the fact that I feel pretty uncomfortable dressed the way I am, because I came to San Diego and United Airlines sent my luggage to Arkansas. So anyway, that's my only disclosure. So what happens when we have an adverse event? And I want to separate right at the beginning the difference between equipment failure that you go through normal troubleshooting and the equipment goes back into service, and when you have an event that that has an injury to the patient or requires that a device comes out of service and gets removed along with all the pieces that go forward. I think the first thing we all have to do, and we all want to do, is our patient safe? Is the patient safe? Has there been an injury to this patient? If there isn't, we have to, we'll go through some steps that we need to take to work around that. Responding to an adverse event is a team process, but I think perhaps in most operating rooms, your nurse specialists, your educators, your managers help you through those events if you have them, and at the end of the day, you really don't see all of the steps that goes on in the background, and I just want to heighten your awareness around that. But in any event, just like a lot of the things we do as a team, we want to respond to things in a way that's standardized, that's understood by all the disciplines, and it fosters interdisciplinary communications. Remember, if you have an adverse event, a patient injury that is an adverse event, near misses are so valuable. We can learn so much about how we're practicing, what we're doing, and how we can hurt our patients when we look at those days where we went home at night and said, oh my God, something awful could have happened today, but it didn't. Troubleshooting, most of those kinds of events really help us in doing this. So when we look at this whole process, it really started back in the 1990s. There was a lot of awareness about device failures, and Congress acted to pass the Medical Device Act. As a result of that, the MAUDE database was introduced in 1993. And now today, 26 states have laws that require the reporting of adverse events. When you look at the Joint Commission, everybody says, what's the standard around this? The Joint Commission doesn't have a distinct standard around events reporting, but when they review your sentinel events, and you've had one, they will look at how you manage devices that failed in relationship to an event. So you need to be prepared to be able to answer those kinds of questions. And the National Quality Forum does include this in their product categories as well. So we have broken this down into 3 steps. First step is, what do you do immediately? You ask, again, is the patient safe? And if the patient is, you manage the device. If the patient isn't, you immediately take steps to make the patient safe. And it may include up to aborting surgery as well. Each of your institutions will have different ways that this kind of work gets reported out, who's responsible, and how the team works together with your risk managers. I can't prescribe one single way to do it, but knowing it's standardized and in place so that if you have to do these things, it becomes not how do I do this, but let's go through the steps and move them forward. An important piece of it follows disclosure to families and transparency. There's more and more attention to that as we move forward in our work. When you have had an event, you need to make sure that you sequester the generator, the instruments, and the packaging. There's a lot of keys to the answers that we look at when we start looking at lot numbers. We need to make sure we have all of those things, and they need to be recorded. Oftentimes, your nurse in your room, your circulating nurse, is the person who completes the safety report for you, and you'll get an email a couple days later from the nurse manager or the CNS saying, can you respond to this? What happened, and how's the patient? I think probably everybody's gotten those kinds of emails through the reporting system, probably on a fairly regular basis. You want to make sure that they go to a designated location and that the incident report is fully completed as well. The next phase is really the due diligence around the event, and some of my colleagues talked about the things that you have to do, searching the literature and finding out from other people what's gone on. When the report is committed, your patient safety, risk management needs to partner with your product safety officer or the person who does that work for you to reconstruct the event, gather testimony from the individuals, and work with the folks who do your mandatory reporting to the FDA around these kinds of issues. We look at the databases, we look at clinical engineering to look at the products. Are there other similar problems in the databases related to that problem? If the generator then continues to malfunction, it needs to be pulled out of service completely. If it clears all of the function and healthcare quality has really passed off on it, it can be placed back into service. The final phase is assessing the risk. This is the place we don't ever want to be in because it usually means that something very bad has happened to a patient. There's two pathways that you can take with this. If there's a potential for claim, if the answer is no, you begin working closer with your industry partner around the device failure. You look for the cause. If there's been an event that really, and a patient injury, a negative outcome, where there's some question about the event, you want to work through your risk management department to make sure the next step, whether it be injury or bringing in a neutral third-party investigator for you. But at the end of the day, all of this loops into your risk management work. It goes back to your QI directors or whichever body you have that reviews events, and it closes the loop. So I hope I've given you a very high-level overview of how to manage devices, and I thank you for the chance to be here and speak to you today.
Charlotte, that was perfect. Thank you very much.